running through some of the challenges of PSP and how we can confront them, and how probably to get the best care if you are living with PSP or other, we call them atypical Parkinson's disease, so that's such as MSA and CBD that we've also spoken about today. But really it's not one person that manages them, it actually ends up being a whole team. So a neurologist such as Jim or David, an occupational therapist such as Nick, or a speech like Amanda, usually a physiotherapist will come into play, often social work and counselling. So it's a whole team of allied health professionals that work together to actually help manage different aspects of this particular illness. And really, they're so complex and potentially overwhelming, we really do need that team to cover all aspects to improve quality of life as best we possibly can. So this is actually a quote that I took from PSP in the UK. I have two strong legs, but I can move when I walk, I fall. I have a strong voice, but when I talk, no one understands. I have good vision, but I cannot see, I cannot read. My throat is healthy, but I cannot eat without choking. That's very much how many people with PSP experience the illness, is that they know exactly what they want to do, but the way the illness is impacting upon them is they just can no longer do those things that we just consider every day anymore. So some of the challenges that we have with PSP is that, and with similar conditions, is they impact upon everyone. It's not just the person who's living with the condition, but it's the family as well. It becomes very much a condition that affects all aspects of your life, and certainly it changes the way that people's future is. So that you might have got to 65 and retired, and that not long after that you've been diagnosed with PSP, that changes absolutely everything around it. Life changes. They're challenging in many, many ways. Communication's affected. It changes the way that we communicate with both within the family but also externally. Emotionally we get quite impacted upon by these things because things change. With some of them we see some change in cognition, so change in the way we think and we can reason. PSP in particular, we see an associated irritability and a frustration that comes through very much with people living with the conditions. Unfortunately, our treatments are very, very limited, and they revolve largely around symptom control. At the moment, there's no medication that we can give you that will slow the progression of these illnesses down. Can everyone hear me? So our treatment is very much focused around providing symptom management and symptom control medication. It'll pass in a minute as well because it's sunny in a minute. The illnesses are also quite rare. They're poorly understood. You walk into the GP, as Jim said this morning, the GP may have been lucky to see one person with PSP in his whole career. That's similar if you think about other healthcare services as well. So if you go into the local emergency department, they're not going to know what PSP is or some of the other illnesses, and in fact if you Google PSP, what you actually get is you get lots of things about Sony PlayStation. Similarly with MSA and CBD, they're not sort of on the radar of other healthcare professionals. They're unknown. So it becomes very frustrating for people with the conditions and carers because we're having to actually explain what the disease is to people who they're thinking they're about to entrust their care of the person they love too. So that's another way that they're often very frustrated. And sometimes our symptoms appear unpredictable. And certainly when we wrote the PSP member, and when he was sort of saying that often things would happen at 9 o'clock on a Saturday night when there's absolutely no one to call. So sometimes we need to have some resources in place, so learning a bit more about the conditions is incredibly important. But the challenges start at the beginning. Misdiagnosis is often common. Most people aren't diagnosed initially with PSP. They're diagnosed with something else, commonly Parkinson's disease. Similarly with MSA and CBS, they're usually diagnosed with something else, or they're left in the nether region and we're not diagnostic phase is often lengthy. We're often doing stuff, we're doing MRIs, we're taking samples of spinal fluid, we're doing lots of different tests. And often they're inconclusive and they're not actually coming into everything in particular. It's very frustrating when you get to a lot of people with close diagnosis. It's a diagnosis based on narrowing the field down of the symptoms that someone is exhibiting and often on the progression that someone may well have experienced. Unfortunately for these conditions, we can't get a conclusive diagnosis until post-mortem. There's no foolproof diagnosis before then. There's no known cause. We do know these illnesses aren't hereditary. They tend to occur spontaneously. So some of the challenges that are going to confront us once we've actually got some semblance of diagnosis that there is limited response to medication treatments. Often we try some Parkinson's treatments. We might get some response for a brief period of time, but that's often not sustained for longer than 3 months. And often if we keep persisting with those sort of treatments, we actually start to see some deleterious side effects, particularly with problem with blood pressure regulation and problem with dizziness and fainting. There's more disability because whilst there's a bit less tremor than Parkinson's, there's often much more rigidity and muscle stiffness. So people become more immobile, often quite earlier. It really affects people who are younger. Falls are very, very common. And often a very common early symptom. And quite, because of the muscle stiffness, we change the way our body sits. Posture changes. So we tend to have quite stiff legs, quite stiff back muscles, and so we're top heavy. So our centre of gravity has gone from sitting within our pelvis to sitting within our rib cage, often towards the back, so we tend to fall backwards. We contend that with maybe some blood pressure fluctuations, so we're still taking a little bit of levodopa, and falls are very, very common, and often a thing that can result in some significant injury with these conditions. We have problem with continence. Constipation can be very, very common in these conditions. Often because we're not drinking as much fluid because it's a bit harder to swallow. But also we see the bowel and the gut slowing down as well. We often have urinary difficulties. Again, physically it's hard to actually get to the toilet sometimes. But sometimes, particularly in MSA, the bladder can become affected and we don't actually get rid of all the fluid that's in the bladder effectively. Thinking changes. We become more irritable. And in PSP in particular, there's often quite a significant dementia that starts to occur at some point of the illness, and we know that that cognition and reasoning changes quite significantly. People don't think clearly. Sometimes we make inappropriate or irrational decisions, and often we might become just a bit aggressive and a bit irritable. Often we can manage some of these symptoms, but it's very confronting because you're dealing with a physical illness, but also something that starts to change someone's personality and the way they're thinking, and the way they've always related to you. Communication becomes a bit more difficult. Slurring of speech can occur. And people can feel that if they're not as confident when they eat, they might feel they might have some choking sensations. Often slurring of speech can be quite a complex one because your speech is a bit slurred and you don't move as well. And if you're still out in the community, there can be this misconception that people have been drinking, that they're drunk, which is wrong. We know it's part of the condition. And in PSP in particular, if you might have enjoyed reading, your eye movements are often altered. Often it's harder to read. You have to be careful where you position things. Often it might be if you're sitting in your favourite lounge chair, you can't see the TV anymore because it's actually sort of sitting too low, as the direction of your gaze is shifted upwards. So some practical strategies to contend with the challenges. Pause. We know that happen frequently and happen often forwards, usually without warning and related to muscular stiffness, and often that shuffling gait that we develop with these conditions. If someone is falling, I usually check blood pressure. When we are changing, and often if we've lost some weight because of these conditions, blood pressure might be a bit lower. We might have some postural fluctuations, so when we go from sitting to standing, the blood pressure might drop. And often when we do change those posture, because the muscles are stiffer, you're a bit wobblier and you don't compensate as well, if the blood pressure's dropping, you're at real risk of actually having a bit of a fall. Eye problems in PSP in particular may cause an issue because you can't see tripping hazards. Fatigue. You've got constantly tight and stiff muscles. You're walking against constant resistance. You're going to get tired. Towards the end of the day, that's going to present, in fact, you're probably going to shuffle a bit more. It's hard to turn around. And sometimes when we do go to sit down, we do what we call an en bloc sitting. And many people who've got PSP or these conditions, we know what that is, because when you get towards the edge of the chair or an approximation of the edge of the chair, you just drop. And if it's a chair such as we've got today, you drop with a normal sized body, you actually might sort of tip over on the chair. I'm really not winning. So sitting down can be quite difficult. And often if you are sort of sitting on block, if you're not quite at the end of the chair properly, you might hit it and just deflect off the chair and end up on the floor. The falls do occur. They're unpredictable, they're hard to avoid. And if someone falls over, it's no reflection that you're not giving them enough supervision or care, because we know in these conditions they do occur. The best thing that we can do when falls do occur is not to panic. Check that the person who's fallen over, that they haven't injured themselves. If you think there's any injury, or if there's any feelings of soreness, stiffness or pain, phone the ambulance. Don't attempt to move them. So that might just make the pain a bit worse, or if unfortunately there's been a fracture, it could aggravate that. Get help in trying to get someone up if you can. Sometimes it's not possible, particularly if it's in the middle of the night. But only attempt to actually get someone up, back on their feet or back into their chair, if you feel confident in doing so that you won't injure yourself as a carer. If you're not confident, dial 000. Explain the situation to the operator. And they'll send the emergency personnel around to you. That might be the ambulance, it might be the police, it might be the fire brigade. The fire brigade particularly, because they're really quite good at getting people up and they're quite sensitive. And they're quite nice to come around in the middle of the night. Doesn't necessarily mean they're going to pass you off to hospital unless they're worried about injury. But it's important for carers in particular that you don't put yourself at risk and you don't injure yourself. To reduce some of our falls, we can do stuff like, as people are saying, we declutter environments. We talk to OTs and physios about an appropriate walking aid. Sometimes with PSP, if we've got a bit of a shuffly gait, or with any safety, a walking stick might not be the appropriate aid. You might need to actually move to maybe a four-wheel frame quite quickly, because that gives you a bit more of a base. And you're less likely to hold the stick up in the air before with the stick pointing in the air. The aids, and walking aids tend to be a little bit like a drug. They're individually prescribed for the person. So never just be tempted to go and hire something or go and buy something. It's always worthwhile actually seeking out professional advice in regards to it. Often that professional can also talk to you about sort of getting something that you're looking into the future. That might not be a little bit excessive for your needs right now, but into the future might be something that we can prognosticate and think might be a bit suitable for the future. There might be something that's a full walking frame is going to be good, but because you've got stiff muscles and this posture and stability, you're going to get one that's weighted at the front so that it's front heavy, so that you're less likely to fall backwards with it. In the same way that we look at your home environment, you might put some grab rails and bathrooms, put a shower basin if you can just wheel in a chair. We do lots of different things to those two layers. Sometimes the kiddies do as well. Some of the issues that we do have with these conditions are some visual changes. So seeing, we don't have to identify tripping habits, but also the way we see and interpret things can change. With supranuclear pearls in particular, the direction of gaze will change. We often have delayed visual reflex. Some people with these conditions will experience some blepharospasm, which is where you sort of have a twitching or a closure of the eyes because the muscles controlling the eye thinking become very, very effective. Some people notice that they have increased watering of their eyes. And people often can be light sensitive. Again, if they've got a reduced blip, can be a bit light sensitive. So we often need to be very, very aware of this in our daily care. So ideally, we're trying, particularly with PSP, we're trying to get people within visual range. Be aware that when someone's sitting down, is what they want to see, where they need it to be. Going into hospitals can be particularly difficult because we're lovely, we've got the TVs up on the walls, yet when you're lying in bed, all you can see is the blank wall in front of you. You actually can't see the TV, which is above you directly from the gaze. So we need to sort of see if we can modify those sort of things. And again, look in your home environment, things might need to be changed a little bit. If you've got lots of problems with eye twitching or eye closure, talk to a neurologist. We might be able to use some Botox to actually help sort of manage and minimise that spasming. Good and regular eye care is very, very important, particularly if you've got a bit of a delay or reduced blink. That might be some regular eye drops. We also think we can get some nice ointments which are a bit thicker than the eye drops, made of the same thing. If they keep the eyes nice and moist, particularly if you don't close your eyes properly or effectively at night time. And be a bit creative, look for alternative mediums. So if you've always enjoyed reading books, maybe sort of getting books from Vision Australia, which is actually like recorded, can be more valuable. There's radio for the print and care available. So you can actually listen to someone read the newspapers out to you. So there's a whole range of different mediums. And sometimes, whilst we're not blind, we can tap into the services of agencies such as Vision Australia to actually access their resources. And often it's a very, very small membership fee to actually access some of those things. And often they can also help out with lots of other different aids as well. Some cognition changes occur, so thinking changes. Often short-term memories quite impaired, so people don't remember things as well. Multitasking is often really quite difficult. So it's hard to do 2 or 3 things at once. And often if you care for someone with PSP or MSA, these conditions, we need to be really aware that people who can't have multitask as they used to. So we might be sort of thinking, okay, well, while we're walking with the person with the condition, we're not having a chat about how really wonderful the weather is today. The person who's living with the PSP is probably going to struggle to keep walking in response to a conversation. So sometimes we need to be really aware that multitasking is hard. We need to minimise some of the stimulation when we're doing some of the tasks. That might mean when we're having dinner in the evening, have a protected mealtime. No TV, no radio. You're just going together. Get into the habit of actually, when you're actually sort of having a conversation, you've got to pop the influence down on the plate before you actually start talking. So for the person who plays food, we make sure we've actually had a swallow and empty your mouth before we start talking. Don't sort of try and talk with your mouth full and try and swallow it. Sometimes you might do normally as a very really fast conversation. You know, people with this condition can be very impetuous. So they can be a little bit unpredictable. You might also say, just wait there, John, I'll be with you in a moment. And before you've actually got there in a moment, they've already got up and started to walk away to do what they wanted to do anyway, before getting assistance. It's not done deliberately, it's just something that we know is characteristic of these conditions. Sometimes people become quite aggressive, quite frustrated. Again, that's as we start to see some of the cognition change. And also as people start to have some awareness of the physical limitations of these illnesses put on them, they do get frustrated and angry and a bit grumpy. And that's like, unfortunately that's okay. But even with these conditions, sometimes we might, as carers, we might need to actually realise that the best way we can manage it if someone's particularly grumpy is maybe withdraw for a while. Or just put up with it. They're not nice things to be living with. We're allowed to be grumpy from time to time. If it's a problem, one of the things that we actually would suggest that people actually do is that we sort of seek some assistance to actually manage the behavioural changes. And to exacerbate all the cognition changes, the communication alterations that we have also make things just much harder. And so you can imagine that someone will get irritable if you're having to ask them 3 or 4 times what they've actually said because the words haven't come out in the right order. So the best thing we can do is patient. Take a deep breath. Nothing needs to be done tomorrow, it can wait. Just slow down. For communication, we need to establish our environments well. Turn the radio down, switch off the TV, so that we can concentrate on what's being said. Work with our speech pathologists on getting good communication devices in place. And often getting used to using communication device early on. That's often a really good way to manage some of the fatigue. Make our environment safe. Reduce the bad impact of that impetuousness. Seek out some assistance from a psychiatrist. Often used with antidepressants are really good for emotional issues. So if you've got sort of heightened emotions, particularly emotional ability, some antidepressants can assist with that. And also if someone's a bit irritable, sometimes that irritability and maybe even some anxiety is often related to a little bit of lower burden depression. So we might need to assess for depression and treat appropriately. Accessing counselling is also really good. Probably both for the person living with PSP, but also for carers as well. Making sure that you're having got an emotional outlet for some of the frustrations that you're both probably experiencing. There's probably an under-recognised symptom of these conditions. We know that we're associated with conditions such as cancer and lots of pain, but the pain that we tend to experience with these musculoskeletal conditions is often associated with muscle stiffness, often contractures and stiffness and changes in posture because the muscles get quite tight. So it's more, rather than acute stabbing or a very acute pain, it's often a very dull, throbbing, sort of consistent sort of pain that people experience. It's often sort of an uncomfortable sort of pain. And often it's a long-term pain. We need to be particularly careful and aggressive and good at managing the pain we experience in these conditions. And it's often not by giving you lots of morphine or lots of evoking analgesia or analgesia. It's often by treating some of the underlying symptoms. So some of the ways that we're going to manage the pain is to take time where it hurts. You're sort of saying, I've got a really, really bad headache, but what we might actually sort of see, like really do an examination, well, the headache's possibly like the fact that you've got really stiff trapezius muscles, so the back of your neck's really stiff, so you've got a change in posture. And the headache's more, not so much from a headache, but it's more that the muscles are so tight. You might need to look at that. Often we consult with our neurologist colleagues with that. We might look at some Botox again if it's muscle stiffness, maybe some clonazepam, which is a benzodiazepine, which is particularly good at sort of loosening muscles. You might use some analgesia, but it might be, rather than analgesia reduced from acute pain, it might be something that's more long-standing sort of analgesia, something that's often not significantly high in dosage, but something we give constantly to actually help manage that pain. Sometimes you don't have to reach for the pill bottle or the Botox needle. We can actually use things such as gentle massage and hot packs or warm packs. We don't know too much these days, but we might actually sort of cook ourselves. But they can actually help. That's something that's a bit harder to work out, and it tends to be very, very individual. Generally, if we actually do something and it actually feels that you're getting some relief and it feels comfortable, that's probably something worth persisting in. I know earlier on today someone mentioned about what was the value of a myotherapist. A myotherapist is someone who looks at muscles and does a lot of massage and manipulation techniques. For some people that might be something that works, it might be good to provide some comfort. For other people it might not. Often sort of say, particularly with muscular manipulation, we tend to sort of steer people more towards some very gentle sort of massage. If your muscles are tight already, having sort of someone probing and doing some deep tissue massage will be quite uncomfortable, quite unpleasant. Continence. This is probably one of the most frustrating aspects that affects people with these conditions. And largely the continence is impacted by a number of different ways. Incontinence can occur, but it's usually not that you're actually becoming incontinent. It's often because you're so physically disabled it's hard to get to the toilet. So it's more of a functional continence as in sort of, or rather than losing bladder control. We know constipation is very, very common in these conditions. MSA particularly is associated with urinary retention and holding the volume of urine in the bladder, which can sort of predispose us to getting problems with urinary tract infection. And because we have some blood pressure fluctuations, we tend to experience a little bit of what we call nocturia, the frequency of urination at night time. So if your blood pressure is a bit low during the day, we tend to retain a little bit of fluid. So often it pulls a little bit in our ankles, particularly if we're not walking around as much. You've got to get at night time when you pop your feet up. That fluid will start to shoot back into the body, the kidneys will start to diurese it, so you have more urine actually being produced at that particular time. So often we find that at the time when we're wanting to settle down at the end of the night, when everyone's exhausted, you keep being woken up by your bladder, and often you have to keep waking up and care up to say, help me get to the toilet. So some of the ways that we would manage it, continence, probably the first stop that I would suggest with anyone who's having a problem with continence, along with talking to your neurologist or talking with us at Parkinson's Victoria and PSP Australia, is that talk to your continence association as well. Often we're going to need to access a continence aid, and they're the best people who actually point you in the right direction of either a local continence nurse or to actually access the most cheapest and cost-effective sort of continence aids. Because you often might need to actually consider using a continence pad or condom drainage, particularly if we're still active in the community. And even though we've got an online public toilet bank that we can map our route via our public toilets, sometimes they're not that hard to access. And sometimes actually are a bit difficult to actually use because they might have adequate disabled facilities, or they might actually just not be in a fit state sometimes. So sometimes it might be better to use continence devices, and sometimes it's actually quite a nice insurance policy as well. Just because it's there, it doesn't mean you have to use it. You manage bowels. You sort of say, increase your fluid and your fibre intake. Now, fluid intake can be particularly difficult to increase in these conditions because the swallows change. So sometimes you might need to actually be more aware of some of the fluid contained fruits, so like with our fruit purees that have a lot of fluid in it, those have a lot of fibre in it. You might need to take a regular period or laxative. The one that we've tended to find that is probably the most effective is a medication called Novacol. It's great. It comes in sachet form, you can dilute it into various fluids. The big problem with Novacol is it doesn't thicken readily. It doesn't, and even if you put your normal thickener in it to might thicken a drink with, it just tends to separate and it doesn't work well. The only thickener that we found that works particularly well is xanthan gum, which is a food thickener, which is a bit hard to get hold of. But often if you're clipped in with a speech therapist who's helping you with your secretion and your swallow problems, they'll often have a way that they can get hold of some for you. Because it is effective, it's often worth going that extra mile. Sometimes the other substances such as agorol and those drugs which are irritants, we'd probably tend to avoid using, particularly if the swallows are a bit impaired, because the last thing you really want is to get an irritant sort of down in your bronchus or in your lungs, because that's just going to irritate down there as opposed to irritating the bowel and making the bowel move. For people with problems with bladders with MSA, we sort of say we need to get regular ultrasounds of your bladder. If you're holding more than about 120 mils of a residual volume, we tend to say, we think we probably might need to, in a situation where we might need to introduce some intermittent catheterisation, because that puts you at really significant risk of getting urinary tract infections if you're holding that volume of urine in your bladder. So we have to be particularly aware of that. And again, if you're clicked into a continence service, they'll often have district nurses who can come around to your home with a bladder scanner and they can check how you're travelling. And they'll also help you out with any catheterisation if that's actually needed. Surviving hospital, as I mentioned, these conditions are rare. Your GP is probably going to really look after some of these conditions, and your local hospital is going to really struggle. Again, if you're living with a condition, if you're the carer, you're the expert. But we have to be a very gentle expert when we meet some of our mainstream hospital systems, because they like to think that they're the experts. So somehow we have to be diplomatic and impart knowledge to our colleagues and the people that are going to look after us in acute hospitals in a way that they don't realise that they're actually being told what to do. So diplomacy is in order. Share information with the hospital staff. What I've seen a lot of people do is have a little bit of a diary of what it's like. What you do, when you do things, how long it takes, what doesn't work, what does work. Stuff that the wealth of knowledge that you build up as you're living with these conditions. So share that with hospital staff. And reduce some of the stress that you experience when maybe you've got to sort of admit someone who's living with PSP into hospital. Because you're going to have that first barrier and say, PSP, what's that? Or MSA, what's that? You're not going to know. So sharing some of that information. The name of the diagnosis isn't that important. It's actually people who know how to deliver the care, and making sure the care that's delivered is the best is the most important thing. If you filled in advanced medical directives, make sure that you make the hospital staff aware of those. And so that you're also probably amenable to discussions surrounding those, particularly if it's an acute stay in hospital because of something that's happened, either a chest infection or something significant like that. Always have an up-to-date list of medications. If you can, take the drugs in with you. And if it's not working in hospital, if things aren't going well, speak up. Ask to speak to the nurse in charge of the ward. That hasn't worked. Ask to speak to the patient liaison. Usually by the time you've actually got to that stage where you actually ask them to speak to someone who's in that designated role to allow the patients to deal with problems and difficulties, people will start to take it seriously. And all of our hospitals in Victoria have access to a patient liaison 24 hours a day, 7 days a week now. Might just be someone who's a nursing supervisor who'll hand it on to a daytime full-time liaison officer, but it will actually occur. But the care we need to deliver is multidisciplinary in nature. These are complex conditions, and they need to be managed by a whole raft of healthcare professionals. You carry out the care on a continuum of illness, so you can never get too much at the beginning. It's often worthwhile to sort of, if you recent diagnosis, is to seek out some other healthcare professionals so we can get baselines. If you happen to live close enough to a designated mental disorder service, it's worthwhile seeing if you can get a referral in there early on. In Melbourne, we've got a couple of really quite good ones. We've got one out at One Turner Health. We've got one just down the road at the Kingston Centre, which is part of Southern Health. They're specific to these conditions, Parkinson's disease and these atypical Parkinson's conditions. It's really good getting seen early on. You might not need to go back there for a year or so, but at least when you go back there, they know who you are. Sometimes that multidisciplinary care, particularly if you live a bit proximal to Melbourne, you have to cobble together using other services. Our hospitals will have community-based rehab services, which you can often tap into, get a referral to if it's a specific issue. They're time limited. So a community-based rehab will only keep them on their books for about 6 weeks, then they have to discharge you. That's part of their funding restriction. sometimes we can access some of these services in the community. It's a bit harder through an enhanced primary care plan, which for physio, OT, speech therapists will give you up to 5 funded visits by Medicare. That's often not going to give you the multidisciplinary care, but it might give you some focus of care if you've got a particular issue. It might be that if you're having some problem with communication and swallow, you can get a referral for an enhanced primary care plan for speech pathology, tap into a Medicare accredited speech pathologist, and you can see them for 5 sort of weeks at a time. And the advantage is they can often do that in your own home. So that's actually a real advantage of actually being delivered in your own home. But it's not, doesn't tend to be multidisciplinary in nature. And unfortunately, we can only access one of these once a year. So they're quite restricted. Although you can access an enhanced primary care plan mental health for up to 10 visits by a counsellor or visits to a counsellor alongside a normal enhanced primary care plan to address some of the emotional or psychological needs. So I'm just about to finish, and probably we're about on time. I'll have to continue with the elements. Managing these conditions is a team event. Things and needs change as the illness progresses. You're going to need to dip in and out of services from time to time, and you're going to have to be aware that you're going to have to share the journey with a lot of other different healthcare professionals, and hopefully that will be something we can do together. It's very individual. No two people are ever the same. It's quite complex for us as healthcare professionals as well. And we haven't got one formula that fits everyone. We have to change things, which I guess for me is that it's one of the ways we can actually be creative in the way that we deliver care. Quality of life is possible with good management. And one thing that's probably really important about these questions is to have a good sense of what your quality of life actually is. And realise what's important to you in life so that we can promote that. And look into something as easy as like, I'm happy in having a shower every second day, because having a shower exhausts me. I don't feel I need to have one every day, I'm not out in the garden anymore. So you actually consider there's something potentially something that you want to do. Or it might be that having a shower every day is very important to you, so that it might need to facilitate that. Never hesitate to ask for help. Put your hand up early on. Always feel recommended, because unfortunately you might have to continue with your wait list here and there. It's usually me or Di, or perhaps Brianna or Paul, but there's always someone there. If we can't answer your queries straight away, we'll always do a little bit of research and we'll get back to you. But often in regards to finding a service that might be appropriate for you to look into. So I think that's all I've actually got to say to you today.